Hello everyone, I am going to give a presentation today on neurological considerations for the HSD and EDS population, so hypermobility spectrum disorder and Ehlers-Danlos syndromes. Just trying to get some people to think outside of our stereotypical orthopedic group that we think of with this patient population. So what I'm going to go through is just briefly the common presentation of the systems that are involved with somebody with these underlying genetic components of hypermobility spectrum disorder or Ehlers-Danlos syndrome. I'm going to review in more detail in this presentation today on the neurological issues that we see more commonly with HSD and EDS, and then how to discuss, we're going to discuss how to recognize those conditions with the signs and symptoms and see if we can start to differentiate them between each other. And then just briefly towards the end, start to talk about mast cell activation syndrome and dysautonomia that also presents in this patient population that will play a role in neurological disorders as well. So a brief review of connective tissue. The human body is made up of nervous, muscular, epithelial, and connective tissue. The connective tissue has a lot of important things that it does in the body. It helps to package and compartmentalize things. It'll support and protect or binds and separates the organs and other tissues in the body. Deals with protection, defense, and repair, so it does have a role in scar tissue formation, the production of inflammation, and the defense against invading bacteria or other substances through some molecular components of connective tissue. Works as insulation. Adipose tissue specifically is a connective tissue, and that insulates the body and also stores energy. Works with transportation as well. Blood is considered a type of connective tissue that delivers oxygen and nutrients throughout the body. And then connective tissue also plays a role in force transferring throughout the body as well. It's found absolutely everywhere. It's the most abundant tissue in our bodies. Again, found in most systems. It's found in fibrous tissues, fat, bone, bone marrow, cartilage, tendon, the gastrointestinal wall, skin, blood vessel walls. So it's not just limited to the joints as we tend to think of hypermobility conditions. Connective tissue also encloses the brain and spinal column as well. So the connective tissue disorder, when a patient presents with one, is not going to limit itself to one area of the body. It's going to affect all the connective tissue for that individual that's associated with the mutation that's present for that disorder. The severity might range from person to person and within the own individual based on the system as well. So we're going to see a variety of patient presentations, but it's going to be more global than just the joints affected. Ehlers-Danlos syndrome specifically is a dysfunction, whether it's the abnormal synthesis or the organization of collagen types 1, 3, or 5. Some more rare subtypes can involve abnormalities in the proteoglycans and glycoproteins as well. Type 1 collagen, typically we see affected skin, bone, tendon, blood vessel, cornea, and organs. Type 3 is the supporting mesh and soft tissues and organs. And type 5 also involves the placenta, the cornea, the skin, and tendons. So healthy connective tissue, what we should see is normal collagen that's going to make the connective tissue strong. It's going to limit the stretching of the tissue. When it does stretch, it's not going to break easily. When it does break, it's going to heal well. When we have a connective tissue disorder, such as in Ehlers-Danlos syndrome, the faulty collagen that is creative makes the connective tissue weak. It's going to stretch easily, and it's also going to break easily. And when it does break, it's not going to heal well. The language that we use, joint hypermobility syndrome, is no longer used. Joint hypermobility is part of the hypermobility spectrum disorder classification system. The current terminology that we're using is generalized joint hypermobility, hypermobility spectrum disorder, and Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome, the wordy definition is that it is a group of genetically heterogenous heritable connective tissue disorders. So we're seeing different genes involved that are presenting as connective tissue disorders, depending on which type of Ehlers-Danlos syndrome is diagnosed. It's not only a joint hypermobility disorder, it affects all the connective tissue that's going to be involved with that genetic mutation. Currently, there's 13 different classifications, one unclassified mutation. They can all be genetically tested for except for hypermobile EDS, which is unfortunately the most common of all of them. It can be autosomal dominant or recessive depending on the type of EDS that's present. And hypermobile EDS is currently tested through clinical presentation using a diagnostic checklist that came out in 2017 and is provided by the EDS Society and can be found on their website. So here are the different types of classifications for Ehlers-Danlos syndrome. We have classical, classic-like, cardiac, valvular, vascular, hypermobile, arthrochalasia, dermatosparaxis, kyphoscoliotic, brittle cornea syndrome, spondylodysplastic, muscular contractural, myopathic, periodontal. There's an unclassified AEBP1 mutation, and then hypermobility spectrum disorder is another classification of hypermobility syndromes that are symptomatic. So what are we seeing with these groups? So hypermobility spectrum disorder and Ehlers-Danlos syndromes, well, a lot. And this is what kind of clues us to that we're seeing a genetic issue rather than a localized joint hypermobility problem that's asymptomatic. When we get into the symptomatic hypermobility spectrum disorders, that's where we see the systemic involvement. We're seeing orthopedic issues, yes, but we're also seeing skin involvement, issues with the organs, neurological problems, pain disorders, psychological disorders, gastrointestinal issues, cardiac issues, potentially mast cell activation disorder, and dysautonomia, specifically POTS, postural orthostatic tachycardic syndrome. So this isn't necessarily going to present the same way in every person, but this is certainly, we can see a variety of things similar to these pop up in one person. So the neurological conditions, and I'm going to go through that we really need to be aware of in this population because it is much more prevalent compared with the general population, a cranial cervical instability or atlantoaxial instability. A recent study just found that about 20% of those with EDS have this condition, so upper cervical instability. Intracranial pressure changes are more common. Chiari malformation is found in almost 1 out of every 4 patients with EDS now. Cerebrospinal fluid leaks, whether they're cranial or spinal. Tethered cord syndrome is found in almost half of the patients with Ehlers-Danlos syndrome. Tarlov cyst syndrome, specifically symptomatic Tarlov cysts, are more commonly found in EDS. Eagle syndrome is something that's newly being studied, and mast cell activation syndrome and dysautonomia are very prevalent in this population and can actually affect the neurological system. So to start off looking at, one of the ones that we hear about a lot is this upper cervical instability. So we can have, with upper cervical instability, we can have either cranial cervical instability or atlantoaxial instability. CCI, or cranial cervical instability, is where we have insufficiency of the alar ligament. So the head is no longer stable on C1. So the head is not sitting on the neck where it should be. The skull can sit too far forward or back on the first vertebra. It depends on the patient. And this displacement can compress the brainstem or the spinal cord. So we tend, as the instability gets more severe, we're seeing more of these central neurological deficits. Atlantoaxial instability, so AAI, is insufficiency in the transverse ligament. So C1 is not stable on C2 anymore, and C1 typically is moving forward on C2 in this position. The DENS as well can put pressure on the spinal cord with this, and this part can result in neurological issues with AAI. So with CCI and AAI, signs and symptoms, we can see certainly a lot of neurological things happening, a lot of symptoms that seem to mimic or are very similar to dysautonomia. We see dizziness, vertigo, syncope, fainting, nausea, also similar to dysautonomia. Headaches, a pressure, a heavy sensation in the head. Specifically, we're starting to see more ocular issues, so a headache behind the eyes or pain going into the eyes. Neurological issues like weakness or numbness, paresthesias or paralysis. And of course, this is going to vary depending on the severity of the instability that's present, which this instability can be on a spectrum. The majority of patients are typically on mild approaching moderate, and rarely do we have to refer patients out for surgical consults. A lot of this can be taken care of with the right rehab techniques, but we do tend to see these neurological symptoms as we start to approach that moderate instability. And we can see impaired coordination, balance issues, gait changes, and poor proprioception in the patient as well. Neck stiffness and pain. So this is typically in that suboccipital region, so right at the base of the skull. Pain behind the eyes, again, a lot of ocular issues, pain at the back of the head or even into the scalp itself. And then we can see facial pain as well because we're starting to potentially get compression of the cranial nerves. Neurological issues as well, those cranial nerves, we can see changes in swallowing, shortness of breath, even sleep apnea. And these patients tend to have negative sleep apnea studies done or sleep studies done, or perhaps they're borderline or just abnormal but not abnormal enough. That's typically what we're seeing with this population. That, along with these other symptoms, might be indicative of potentially upper cervical issues. Visual changes can happen, nystagmus, so blurry vision, sensitivities, ringing in the ears, and changes in hearing as well. And fatigue, memory problems, brain fog, sleep disturbances. So again, those could be very similar to dysautonomia. CCI and AAI can look very similar to other things. Can certainly, again, look very similar to dysautonomia, and these two do tend to exist together. We can get some compression of that vagus nerve if we have things not sitting quite right in the C1, C2 area, so it can stimulate and exacerbate dysautonomia. But it can also very much look like dysautonomia. CSF leak is something that also looks very similar: low intracranial pressure, high intracranial pressure, Eagle syndrome, carotid dissection, vertebral artery dissection, cervicogenic headaches, occipital neuralgia, patent foramen ovale, because you actually do get radiated pain with that, TMJ dysfunction, and then mast cell activation disorder. And this in particular, we'll talk a little bit about this in a little bit. This is suspected, this condition, to be potentially a systemic inflammatory driver to the breakdown of the tissue in the upper cervical region. So this might be actually impairing the function of the tissues in the upper cervical spine and breaking them down. But a chicken or the egg scenario, not quite sure which one is leading to which. Testing for CCI and AAI, this is a little bit difficult because especially in the hypermobility spectrum that we're looking at with these patients, this really needs to be investigated by a specialist. Currently, we don't have any testing specifically to recommend in a PT clinic, in any rehab facilities. We're currently right now working to get this information out on hopefully by next year of what to look for, mild, moderate versus severe. So hopefully that'll be coming out. But currently there's not a standard of testing for in clinics to determine if CCI or AAI is present, especially in this population. What we're looking at right now is possibly a compression decompression self-test. So the patient can do this, or the therapist can do this as well, where you compress the cranial cervical junction and then you distract it. So this might be something that triggers symptoms in patients. Decompression might relieve it. So that's something that's a possibility, but currently, again, no specific testing. The type of testing that we typically consider in physical therapy to do aren't necessarily safe on this population to look for upper cervical instability because it can trigger symptoms for many. So again, this is something that for now, doing a clinical investigation of a lot of subjective information could start to point towards this diagnosis. When we're talking about imaging, imaging actually depends on the specialist that the patient might see. They can have either a supine regular cervical MRI done. If we're talking about kind of the top leading neurosurgeons in the US, there's one of the neurosurgeons that uses supine, and the other two are using the upright MRI to look for weighted images of the cranial cervical joint. So again, it's a little bit tricky because you have to know who they're going to see or what's available in your area, including the radiologist as well. The measurements to look for that they should be measuring in these MRIs is something called the Harris measurement or the Bayesian axial interval. These are just the measurements that we're looking for, what we classify as stable or unstable. The clival axial angle, Grab-Oakes measurement, the Bayesian Dens interval, and then one thing that might be done, this is not done, this is primarily done by one of the neurosurgeons, is manual traction relief. So this has to be prescribed, and this is used for testing only, not as a treatment currently. And this has to be prescribed by the neurosurgeon that is investigating the individual. The testing done, like I said, it is dependent on the person that they're going to see, and there's really only a few specialists in this country that deal with cranial cervical instability and hypermobility together. And this is just kind of a squished version of what we should be seeing on that MRI report. So this is something that depending on who you have in the area, you might have to actually send over so that they understand what they're measuring and what the cutoffs are. For providers that are working with patients that might have some sort of upper cervical instability, in treatment, there's no real protocol that's out yet. It's important to understand that patients with hypermobility do respond very differently to treatment, especially with upper cervical instability, than those who don't have an underlying connective tissue disorder. We have to remember that these patients are on a spectrum as well. They can also have mechanical instability, but not functional instability. It's the functional instability that we really need to be concerned about, that they can't physically hold their head onto their neck, and it's causing symptoms for them. You know, are they symptomatic or are they non-symptomatic? If they're non-symptomatic, then it's certainly something that you'd want to monitor and potentially work on in the future, but it might not be something that needs to be addressed currently, depending on the stability of their system. Is there something else driving their symptoms? And this is really important because when we're talking about upper cervical instability, there's a lot of things that are correlated with it, such as tethered cord syndrome, where the pulling down of that spinal cord actually tugs on that cranial cervical junction and exacerbates the upper cervical instability. So work all you want on the upper cervical area. If you don't work lower down in the spine, help realign and stabilize the pelvis, and then reduce the neural tension in that area, you're always going to have that tugging on the upper cervical area. So you have to know something else is driving their symptoms as well. And this includes that it could be something anatomical like tethered cord syndrome, or even a spinal CSF leak, again, pressure's pulling down, but it could be something as simple as the way that they're positioning themselves throughout the day with poor posture, and that forward head, just really hanging the head forward on the neck. So what is there besides the upper cervical joint that can be worked on or of benefit to the patient to release some of their symptoms? And why are they having symptoms now? If they probably have had, you know, upper cervical instability for some time, this is something that they've had underlying. Why is it now that they have symptoms? Is it because of this mast cell correlation and they're having a mast cell flare up on top of things? Have they changed their posture recently? Have they added stress? What is it that's causing their flare up of symptoms now, whereas possibly they didn't have them a year ago? Have you reviewed all postural and ergonomic adjustments that might be helpful to this person? So again, what are the positions that you can help relieve their head pressure on their neck if they're doing anything that is exacerbating their symptoms outside of the clinic? And then we want to consider something other than that local upper cervical manual techniques, possibly. If we have somebody with upper cervical instability, especially that moderate into severe upper cervical instability, they don't usually respond that well to manipulation of the upper cervical spine. And again, there's usually other things in the body, alignment issues in other places, chronic postural issues that they've had, that downward pull of the spinal cord from possibly another condition that's yanking on the cranial cervical joint. So the upper cervical spine might not be the place to start. And a lot of times we talk about this bottom-up technique of starting with the pelvis, going to the abdominal cavity, working in the diaphragm, working on alignment all the way up, working through posture, and then finally getting to the upper cervical region. So there's a little bit of a method to how this is approached with somebody that does have upper cervical instability, to make sure that you're not going to flare them up by going directly to their upper cervical joint first. And it's recommended to rule out tethered cord syndrome. This is a newer recommendation. Again, things that are pulling from lower down in the spine, which are more common to those with hypermobility spectrum disorders and EDS, are going to pull and yank on that upper cervical instability. So we really don't want to do too much treatment intervention if we're not addressing another issue that could be causing the pressure and pull in that area. So what are some treatment strategies? There's some information going around about traction being used for upper cervical instability. This is not a current recommendation, actually. Currently, right now, this is possibly something that we might do for evaluating for upper cervical instability, but we don't have the parameters out quite yet to standardize this, so it's not currently a treatment recommendation. The current treatment recommendations when we're dealing with a hypermobility issue on top of upper cervical instability, specifically with manual techniques, are eye muscle energy techniques to realign C1 or even C2. Craniosacral techniques are possible. This is something that you want to make sure that you are not actually manipulating C1 in any way or the skull off of the spine in any way. This is something where dural techniques might be great, but we don't want to necessarily move things. And neural manipulation techniques tend to work very well for cranial nerves in this area or the nerve roots in the upper cervical spine, and also lower down in the spine, things that can be done in the lumbosacral area, because again, we do tend to see more neural tension in this area for those that have upper cervical instability. So the pelvic floor, the lower spine, that tension down there can have a great influence on the upper cervical spine. So if you cannot work on somebody's upper cervical spine, or they're not responding well when you try to, please start bottom up. So start with the pelvic floor, start on creating a stable base, start on working out some of the neural tension down lower so that you can have a better response up higher. So some of the things that we recommend are pelvic stability work, reducing neural tension in the lumbar spine and the sacrum, improving diaphragmatic mobility, posture cueing and alignment work, cervical proprioceptive work as the head laser, which hopefully we'll have some standards coming out for that. And then when all of that is pain-free, then we can consider cervical and postural strengthening and manipulation. So it is this more self-alignment that we want them to get their body back in place as much as we can before we do any manipulation in this area. The next one moving on is intracranial pressure changes. So hypo or hypertension can be seen in those with HSD and EDS. This is more common in this population. Intracranial hypotension, so low tension, so low pressures, can be secondary to CSF leaks. So this would be a CSF leak in the spine. Signs and symptoms are similar to that of a CSF leak in the spine when we're talking about intracranial hypotension. Headaches are typically relieved when the patient lies down. So that's one of the things that we do see as a flag. Typically the patient or the individual feels worse as the day goes on. Fatigue, headache, just a general feeling of malaise builds up over the day. And a lot of things that resemble dysautonomia. Intracranial hypertension, so an increase in pressure around the brain. The cause isn't specifically known for most, so it can actually be a number of different things. It can be related to venous stenosis, upper cervical instability, causing a compression and decreased flow. It can be caused from a Chiari malformation, again, with the pressure changes from brainstem being pulled down. Too much fluid production might be happening. So whether it's inflammatory changes around the brain, whether it's CSF, but not enough fluid might be absorbed. So if we're creating too much but not absorbing enough, it's going to increase that pressure around the brain. There's a theory that it might be from narrowing of the veins in the skull as well. And then some studies that have come out show that there is some difference in intracranial pressure changes with certain hormones, especially in women. So very interesting. It's typically multifactorial for people. So some of the signs and symptoms that we see is the headache that is worse lying down. That is typically related to hypertension, so an increase in intracranial pressure. Visual disturbances can happen with high or low pressure, as can light sensitivity, tinnitus. Tinnitus sometimes happens with the pulse, especially with intracranial hypertension. Nausea and vomiting is possible with both, changes in vision, stiffness in the neck, exercise intolerance, brain fog, memory difficulties, swelling of the optic nerve sheath, and pain behind the eyes. So you can already see on the second diagnosis that we're bringing up, there's a lot of similarities. We're talking about the eyes again. We're talking about some dysautonomia symptoms. So it does seem similar to upper cervical instability. But again, upper cervical instability can cause changes in pressure. So typically these patients are quite layered in what they're dealing with. So from a therapist perspective or a provider perspective, we're going to refer out. There are certainly, if CCI is something that we're suspecting is feeding into this, then we can certainly work on some of those strategies that we talked about before. But the intracranial pressure changes themselves, we want to refer out to a specialist. Intracranial hypotension, so if we have low pressure around the brain and we're thinking that there's a CSF leak, they need to fix the CSF leak, whether this is through dural patches or surgery. Intracranial hypertension, so an increase in pressure. Some of the things that they might do for this in terms of procedures are spinal taps, health and weight management as well. There is a correlation between obesity and intracranial hypertension, and so lifestyle changes and weight management might be helpful for some. A shunt to increase the drainage from the brain to relieve some of the pressure that's building up, or a stent placement, again, to help the flow out of the brain. So those are all possibilities. The next one we're going to go to is a Chiari malformation. So this is stereotypically a structural defect in the base of the skull and the cerebellum, and we get pulling of the cerebellar tonsils down towards the brain stem. This is a little bit different potentially in those with a connective tissue disorder because the connective tissue is different, not necessarily a structural defect, although they can have that as well. But the cerebellum is herniating down into the spinal cord, and that's going to compress those structures that are in that area. Typically, we want to image this in this population, especially because we have issues typically against gravity. It's hard to hold connective tissue that's dysfunctional up against gravity. So we want to do these upright MRIs for upper cervical instability and also looking for Chiari malformation. With this particular population, we might actually see intermittent Chiari malformation with possible negative testing in the past, even if the patient is on and off symptomatic. So if this is the case, then we might be seeing, and which is more common with Chiari malformation as well, tethered cord syndrome or a CSF leak. And we might see this intermittent positive testing if they're in a higher flare-up or they're having more neural tension from inflammation or they're having an exacerbation of a leak in that area. So some of the symptoms that we see with Chiari malformation are severe head and neck pain, an occipital headache, typically felt at the base of the skull. It's going to feel worse when they cough or sneeze or they're straining in any way. Again, a lot of neurological symptoms might be present. They might have a loss of pain and temperature sensation in their upper torso and arms, loss of muscle strength in the hands and arms. Drop attacks are more common with Chiari malformation, and also more severe upper cervical instability, spasticity, dizziness, balance issues, double or blurred vision, hypersensitivity to bright lights, sleep apnea, sometimes seizure-like activity as well. So again, there's a lot of overlaps potentially between these even three conditions that we're now mentioning, and they can actually have potentially all three of these first ones that we've mentioned happening. So again, layered patients, but it's Chiari malformation tends to come with a little bit more of the almost like a seizure-like look to their neurological symptoms. So for providers, if we're thinking that there might be a Chiari malformation, definitely want to refer out. This isn't anything necessarily that we're going to magically cure. However, it's important to recognize the presence of the other conditions that might be causing the Chiari malformation. And of course, refer out for additional testing. But again, Chiari malformation is that downward pull on the cerebellar tonsils, so down on that brainstem. And this can be caused by a CSF leak, a spinal leak, or tethered cord syndrome. So tethered cord syndrome we'll talk about in a little bit. CSF leak is something that more so we're probably going to refer out. So CSF leak, this again is more common in those with hypermobility spectrum disorder and EDS because the dura is compromised. The dura is connective tissue. So the dura tends to be thinner, more fragile, more susceptible to damage than somebody without a connective tissue disorder. The CSF leaks can be spontaneous, iatrogenic, so if they possibly had an epidural or something in the past, or they can also be traumatic as well. They can mimic POTS and dysautonomia like everything else, and cranial cervical instability and Chiari malformation. So much to overlap. And it can happen anywhere in the spine. They can have it in the thoracolumbar junctions, the cervical area, the cranial CSF leak, which is different than a spinal CSF leak. And then they can also have it in the sacral area as well. CSF leaks, if they're in the spine, can cause intermittent Chiari malformation because of the pressure changes. So you have that downward pull on the spinal cord. It pulls down on the brainstem, the cerebellar tonsils. Typically, this is going to result in low intracranial pressure because, again, we're draining out at the bottom of the spine somewhere. Signs and symptoms, we have a positional headache. So if this is a spinal CSF leak, then it's going to decrease when they're lying down. Cranial CSF leak, it's going to increase actually probably when they lie down because of increased intracranial pressure. They might have pain between the shoulder blades, impaired balance, photophobia, cognition changes, changes in hearing, neck pain or stiffness, dizziness, phonophobia, arm pain or numbness, nausea and vomiting. And then specifically with a cranial leak, they might have a metallic taste in the mouth, fluid draining down the back of the throat, out the nose. That's only stereotypical of a cranial leak. Patients can have both a cranial and a spinal leak, but they are very different in their presentation. So from a provider perspective for a CSF leak, we might be able to help with the alignment around the area of the leak to reduce pressure on the dura that's causing the tear potentially. So is there something ergonomic or postural or alignment-wise that we could do to make things better? Or dural work for anybody in that works with neurological system or cranial sacral. Typically, things are a little bit more helpful when there's a cervical CSF leak. This is anecdotal from some of the people that I work with, that they see it's just a little bit easier to work with cervical CSF leaks, but we can certainly try to improve pressure in a certain area for most people. Horizontal kinesiotaping at the base of the skull in the upper cervical spine and the thoracolumbar junction might help relieve symptoms for some. And then nutritional changes and inflammation reduction. So just trying to decrease the load on the inflammatory reactions that are happening around the spinal area could be helpful for some as well. Referring out, of course, for CSF leak, we definitely want it monitored, and a procedure might be appropriate for some patients, such as a patch. Surgical approaches include anything from minimally invasive patches to more invasive surgical repairs. They typically will always try to patch first before they go on to something more. Tethered cord syndrome is more common in the symptomatic hypermobility population. This could be related to the microtrauma that happens in the lower region of the spinal cord because of the increased mobility. It could also be from the changes in the dura integrity because the dura is a little bit different anatomically. But scar tissue or adhesions can potentially bind down the spinal cord. So it gets tacked down, and typically in the sacral area, and it tethers the cord. So when the cord gets tethered down, it's going to cause a downward pull on the spinal cord, especially with movement. And that can result in a Chiari malformation for some people because you're getting that downward pull that pulls all the way up to the upper cervical spine and into the brain. The MRI, typically, when we're looking at a spine that does not have tethered cord syndrome, you're going to see the conus medullaris end at L2 or higher. When we see tethered cord syndrome in typical tethered cord, the L2 or the conus medullaris is going to terminate below the L2 vertebral body, so L2 or lower. However, in those with EDS, occult tethered cord is something that we are seeing, not necessarily the typical tethered cord syndrome. So it's found in about almost half the patients with EDS. this is something that we're not necessarily going to pick up on a typical MRI, although you might see a difference in the health and presence of the phylum that's there. And there is some work being done right now that shows that there is increased mast cell presence in the abnormal tissue. So the tissue is abnormal in this area when there's underlying connective tissue disorder. And then on top of that, we're seeing abnormal mast cell activity. So mast cell activity, that's important. Chicken or the egg scenario, again, we talked about the upper cervical spine, but chicken or the egg scenario, this mast cell inflammatory process that might be happening could be exacerbating the buildup of the adhesions that are happening around this neurological tissue. So very important to work on mast cells, make sure the patient has that under control, but this could be potentially an inflammatory reaction in abnormal tissue. So it's just not a great combination together. So testing for tethered cord syndrome, again, we're not seeing typical tethered cord syndrome in those with hypermobility spectrum disorders. So MRIs are actually used for ruling out other conditions. So ruling out the big stuff to make sure that we're not missing anything else, but it's not necessarily used for ruling in tethered cord syndrome with a diagnosis of EDS, its underlying things. We might see some things with the phylum in a standard MRI, but again, it's not the standard right now. There's really not necessarily a standard. There's a few things being done by different specialists. A urodynamic study, so seeing how well the neurological system to the bladder is functioning, is actually something that they're looking at. What's called a sign MRI for spinal fluid dynamics is something that's being used as well. And then if an MRI is to be done, there's some practitioners that are using this, and they're looking though at differences with positioning and movement. So it doesn't look like it's getting stuck down when the person is moving positions. So the person might do a prone, a face down, and then a supine MRI, looking at where the phylum is positioned. Is it able to come off of the posterior wall if they go into a prone position? And then one thing that hasn't been done too often, but potentially with the patient, looking at upright MRI, lumbar spine, flexion extension imaging to see how the movement of the phylum happens when the patient actually moves from flexion to extension. Some signs and symptoms that we see with tethered cord syndrome: severe pain in the lower back that radiates into the legs, groin, the pelvic area, lower back pain, groin pain, pelvic pain that happens walking upstairs or walking up hills, urinary urgency or incontinence symptoms while walking up the stairs or with walking. Bladder dysfunction is one of the flags of tethered cord syndrome. So there's a questionnaire that's being worked out to use for screening for tethered cord syndrome. And there's many, many questions that are being developed for the urinary piece of this. So urinary issues could indicate that it's more likely to be some sort of neurological dysfunction in that lumbosacral area. Muscle weakness and numbness in both legs or numbness in the feet. This might be exacerbated with prolonged sitting. Decreased sensation in the pelvic area. The feel that they need to keep their knees bent at night, like they have to have a pillow underneath or they have to pull their knees up. Again, any urinary irregularities, any bowel control issues as well. Sexual dysfunction is actually pretty common as well with tethered cord syndrome. And a history of severe growing pains as a child is just one of those that we're seeing come up, because this is not necessarily something that has dramatically gotten worse one day for these patients. A lot of these patients might have had this for some time, and especially as they go through growth spurts, the neurological tissue is just not keeping up with their growth spurt. So if you have neurological tension already, they actually might have much more severe growing pains as a child. From a provider perspective, there is actually some stuff to do for tethered cord syndrome, depending on specialties. So certainly we want to encourage spinal stability and postural strength to support the surrounding area. So we really want to build from the bottom up. So hips, pelvis, core, reducing inflammation. So through education, whether it's lifestyle, diet, this mast cell component is part of it. If somebody in the area specializes in mast cell treatment or control, or again, more of a holistic view, I think that's very important for these patients because there does seem to be quite a significant mast cell component to tethered cord syndrome. Any other sort of inflammatory reduction that's possible. Neural mobility work, if somebody does neural manipulation, neural gliding, again, we don't want to be tensioning, but this is really just movement, just tolerated movement, so we don't want them to feel any tugging or pulling with any neural movement. Local pain relief, of course, if there's localized pain around that low back or sacral area, or therapeutic techniques to the lumbar spine or the sacrum itself. And it can't be stressed enough, reduce mast cell abnormal activity. So that might not be the provider's specialty, but it's important for the provider to understand, because we really want to make sure that treatments that are done in clinic are long lasting for the patient. But if they're leaving, just with a flare up of mast cell activity each time, the treatment isn't going to hold. So you'll have better treatment results overall if this mast cell component is under control, and certainly refer out. Again, unfortunately, there's not many specialists that deal with occult tethered cord syndrome in the hypermobile symptomatic population. There really aren't many. Surgical interventions in the general population don't necessarily have the best results in terms of improvement, but in that population, they really do the procedure to help stabilize and prevent neurological regression, so progression of the symptoms that they're having. There isn't a whole lot of work right now that has come out on what surgery is looking like for those with an underlying connective tissue disorder and a tethered cord release. Tarlov cyst syndrome. Tarlov cysts, those are little fluid-filled sacs that can develop in some patients along the nerve roots, especially going into the lower spine. The relationship between HSD and EDS and the presence of these cysts is not really explored in detail, but anecdotally there does seem to be a connection between the two, symptomatic Tarlov cyst syndrome. So typically we don't think that this is going to cause an issue for those that do have Tarlov cysts. However, we're seeing this potentially more symptomatically affecting patients with an underlying connective tissue disorder. So for those that are dealing with nerve root pain in the spinal region, especially into the lumbar and sacral areas, that this is something to consider might be an issue for them as a diagnosis or something to look into. The cyst can compress the nerve root, and that can mimic many different things that the patient is referred to a clinic for. Recognition, the referral if needed, treatment as appropriate. That's important for the therapist to understand with this patient and their presentation. So it's really recognizing that this could be an issue, and certainly there are some treatment strategies that could be provided for these patients in clinic. Signs and symptoms overlap a lot of what we've already been talking about. So chronic pain, lower back, below the waist, spreads around the buttocks and legs, can also go into the pelvic area, can be worsened by walking. Sitting can increase pain for some, decrease it for others. It really depends on what's inflamed. Pain can also affect the upper back, the neck, the arms. It depends on where the cysts are located. Symptoms can progressively get worse. Pain can worsen when coughing or sneezing, leg weakness, diminished reflexes, loss of sensation on the skin, changes in bowel or bladder function, difficulty emptying the bladder, constipation, sexual dysfunction, abnormal burning or prickling sensations, or numbness and decreased sensitivity in the legs or feet, tenderness or soreness around the involved area where the cysts are in the spine. They could potentially have chronic headaches, blurred vision. Again, it depends on where these cysts are. And some can actually have progressive thinning or erosion of the bone that lies over the cyst as well on imaging. So again, a lot of these sound like tethered cord syndrome as well. So it's important to understand that there might be one or the other, or even both in some patients. And again, these patients are layered, but it's important to understand that this issue tends to be more problematic when there's an underlying connective tissue disorder present as well. So from a provider perspective, we're referring out. Certainly in the clinic, we can work on pain relief. Absolutely. There's some theories that this might be dural and CSF fluid related, in just difficulty in moving the fluid efficiently throughout the system. So potentially dural work, neural work might be helpful. Spinal stability and postural work can be helpful, correcting muscle imbalances, of course, to help support the area. And then again, we're dealing with a cyst. So we're dealing with an inflammatory change in the area. So we also might want to consider a systemic inflammatory driver. And then, of course, cerebrospinal fluid involvement as well, as a potential cofactor to why this is symptomatic for the person. And of course, refer out. Eagle syndrome is, this is a fairly newer diagnosis that's coming to light. Pain typically is occurring in the head or neck region, and that's from anatomical compression of the surrounding structures, those neurovascular structures. The compression can occur either because of an elongated or misshapen styloid process that's coming off of the skull, or from calcification of the stylohyoid ligament in that area. You can do imaging to see if it's an elongated styloid. Anything that measures greater than 3 centimeters in length is considered an elongated styloid. Vascular eagle syndrome will cause compression to the arteries that pass through the area as well. In the more rare and severe cases with compression, it can actually lead to an ischemic event, so a TIA or a stroke, or it can actually tear part of the blood vessel, which could be at greater risk for those with underlying connective tissue disorders. Compression of the internal jugular vein can also lead to increased intracranial pressure. So we have that hypertension that's present. So Eagle syndrome could be an underlying reason for intracranial hypertension. So Eagle syndrome signs and symptoms: pain on one side of the neck. So anatomically, you're going to feel it where there is compression happening. Rarely they can have pain on both sides. They could have Eagle syndrome on both sides, but that's less common. Sharp shooting pain in that area, so jaw, back of the throat, base of the tongue, ears, neck, or the face as well. Pain with chewing or swallowing, pain turning the neck. Also neurological issues potentially when turning the neck or the head. Pain when palpating the back of the throat, chronic sore throat, tinnitus, ringing or buzzing in the ears, difficulty swallowing, and then the feeling that something's lodged in the throat could occur with this as well. So provider perspective for Eagle syndrome, it really, again, depends on specialties. This is a very specific anatomical area that not everybody dives into in depth throughout their education. So certainly want to refer out to a specialist that might be an ENT is what is in my area that looks at Eagle syndrome. But in clinic wise, those that deal with muscle imbalances in this area, or to refer out to somebody that does specialize with jaw, throat area issues. You can assess the TMJ, the temporomandibular joint, and the upper cervical region, as they play a role in this area as well, and that can possibly help out symptoms. And again, neck and throat specialty, if there is somebody in the area that can work on that, it's highly recommended. So the trifecta is actually very, very, very important when dealing with neurological issues in HSD and EDS. So we have this overlapping of the trifecta of hypermobility spectrum disorder, hypermobile EDS, some of the other types of EDS as well, mast cell activation syndrome, and dysautonomia. And we tend to see this star in the middle. We tend to see the patient that has a varying degree of all of them. Perhaps they look more mast cell flare than even hypermobile. So somewhere in the middle in the star area is where we see the variety of symptoms that pop out in these patients. It is really important to understand the mast cell component along with hypermobility in the nervous system. They're all intercorrelated. Working on one can really affect the other. In one study that they did recently, they found that 96% of patients that had cranial cervical instability had mast cell activation syndrome. So that's pretty important to understand that there's such a high correlation of that. And then also they're finding the presence of abnormal mast cell activity in the localized areas of upper cervical instability and tethered cord syndrome. So again, chicken or the egg scenario, something is happening with mast cells. And again, it's something that really needs to be addressed in tandem with rehabilitative manual work to make sure that we have long-term effects. So MCAS, MCAS itself can be present in anywhere from 10 to 17% of the world's general population. Obviously, it's much more prevalent when we have an underlying connective tissue disorder. The mast cells with this disorder, they just don't respond appropriately. They release too many mediators, or they don't know when to turn off when an invader is already taken care of. They're not very good at communication. Mast cells are also located in most areas of the body. Like connective tissue disorder, so it can get confusing. The signs and symptoms can be located anywhere depending on the person and their reactions. The same person can also have very different reactions to the same triggers depending on how the system responds or how flared up they are in the moment. MCAS can cause systemic inflammation, and it can exacerbate or mimic orthopedic issues, and that's why it's very important to know that as well. It can also exacerbate neurological issues. You want to think systemic issues if there's a lot of things that are happening that are causing issues together, if the patients feel they're kind of going downhill all of a sudden with their health, healing isn't happening at a rate that it really should, something just doesn't feel right in how they're presenting, how they're progressing with things, or how they're trying to rehab out of something. Dysautonomia is really any impairment in the normal regulation of the autonomic nervous system. It's very common with HSD and EDS. It might be related to the integrity of the connective tissue that surrounds the nerves, or more from a central focus. So there is an enlarged amygdala, processing differences, things like that are found in the hypermobile population as well. So anatomically, there are some differences with the connective tissue, but also some other areas of the central system. Most nervous systems can reset themselves after they have a fight or flight event, or even a freeze state. So you have a situation that you deal with and then you move on. That's what the system is supposed to do, is be able to reset. But those with dysautonomia, they're more likely to get stuck in one of those states, and they're not able to regulate the body's systems efficiently anymore. This can also happen with trauma. And when it's in combination with HSD and EDS, it can be very, very difficult to break out of the cycle of dysautonomia that develops. Dysautonomia is reported in about 90% of cases with EDS, so it's very prevalent, and it's nearly always occurring with cranial cervical instability. So again, it could be something that's just comorbidity that pops up at the same time, but it could also be this compression that's happening of the vagus nerve because of rotation of the C1 that's causing some neurovascular compression as well. Signs and symptoms. These are going to look very familiar to a lot of the other things that we were talking about, but poor tolerance to vertical positions, dizziness, vertigo, fainting, irregular heartbeat, chest pain, low blood pressure, GI issues, nausea, visual disturbances, weakness, generalized body weakness, difficulty breathing, shortness of breath. They feel thirsty constantly, or they have salt cravings, difficulty swallowing, anxiety, fatigue, exercise intolerance, migraines, headaches, tremors, impaired sleep, frequent urination, temperature regulation issues, memory and concentration problems, poor appetite and sensitivity to light and or noise. So all of the things that we shouldn't be thinking about during the day is things that could be potentially causing a problem for the person. POTS specifically is postural orthostatic tachycardic syndrome. It's the most commonly diagnosed form of dysautonomia when we're talking about HSD and EDS. One investigation showed that 50% of those with HSD and EDS had this, and 30% had orthostatic intolerance. So we're seeing a large portion of dysautonomia in general. POTS specifically, when we're doing a stand test, we see a difference of an increase by 30 beats per minute on the heart rate when the person goes into standing. So it's an abnormal elevation in heart rate. With this stand test, the patient will lie down for 10 minutes. A heart rate is taken in the supine position. The patient stands up. They stand in place, don't fidget for 10 minutes. The heart rate is recorded again at 2, 5, and 10 minutes. And then it's recommended actually to measure it again at a 2-minute post-test in supine to see if there's more of a drop compared to the pre-test. So this is a way that you can look for POTS by doing the stand test. One test, or have them repeat it multiple times throughout the day or over the course of a few days to see if it's consistent. But POTS is more stereotypically something that we see as to which dysautonomia is present in this population. So with dysautonomia, just in general, we want to avoid frequent positional changes during sessions. We don't want them up and down, especially if they're in a flare-up or if they have chronic uncontrolled dysautonomia. It is not going to leave them feeling well. You can consider a fully supine, so fully horizontal and manual-based session. Consider things that might help improve dysautonomia, biofeedback, breathing exercises, nerve-based interventions. You can work on the muscles that share the nerves with that system. So the accessory nerve, cranial nerves, the upper trap, the sternocleidomastoid. Vestibular work, if it seems to be associated, oculomotor work, again, if it's associated for the person. Vagus nerve resetting exercises by Stanley Rosenberg, and then actually to avoid manipulation on C1, C2, especially when we're looking at moderate to more severe instabilities. We actually don't want to manipulate that because it can trigger a flare-up for patients. So these patients with HSD and EDS, a lot of their diagnoses and comorbidities, they're considered rare and they're not well understood, which makes it difficult, as you can see, when a lot of them look very similar and they tend to be layered and overlapping. And things like dysautonomia can actually feed into neural sensitivity and, cause some other issues in the nervous system. And working on dysautonomia is actually a great way to just introduce treatment into the nervous system to hopefully calm down neural reactions if you're working with the neural system. Most don't have the resources they need for specialists in their local area, so it's very, very, very difficult to find a specialist physician or really any provider that specializes in their clinic specialty and also understanding how that's different when there's an underlying connective tissue disorder. So finding somebody that is an upper cervical instability specialist and also deals with hypermobility spectrum disorder or EDS is very difficult. The same as those who specialize in Chiari, finding somebody that specializes in Chiari and hypermobility is very difficult to find. A lot of these patients have PTSD from their medical appointments. Many feel defeated from not being listened to in the past. As you can see, a lot of these neurological conditions are actually much, much more common with an underlying connective tissue disorder. They seem like very, very big conditions that we shouldn't be seeing come up so frequently, but actually in this population, we are seeing them more frequently. But again, they're on a spectrum. So we typically see mild and maybe approaching moderate for a lot of these conditions. But it can be difficult in understanding that perhaps the patient has mild tethered cord or, a diseased phylum that is causing some of these weird wonky things that are happening. So a lot of them are brushed off, and that happens quite a lot until they find somebody that understands that a lot of these conditions overlap and can be driving each other. So there might be something else driving the pain that's important to know. You want to explore with the individual some of these other conditions that might be driving or exacerbating their pain. So again, with dysautonomia and mast cell reactions, this really adds to inflammation of the neural system. So if we don't have these other conditions under control, they're not going to have optimal results from any plan that's given to them. So you really, really need to treat mast cell inflammatory changes. You need to improve the state of the autonomic nervous system because low vagal term is actually pro-inflammatory. So we need both of these other conditions to be well managed to be able to treat all of these neurological conditions that we just talked about. So in summary, a connective tissue disorder is going to affect all of the connective tissue in the body. That's based on the genetics that are involved. Those with underlying HSD, EDS are going to potentially demonstrate less effective systems overall. So less efficient systems, neurological, gastrointestinal, immune with the mast cells. We just see a lot more that the individual is prone to developing some what we think of as more serious conditions that we wouldn't typically think of popping up so often. Diagnoses that seem to be uncommon in the general population occur with more prevalence in this symptomatic hypermobility population. And the it's really important to understand that the additional comorbidities, these diagnoses, they come on a spectrum of severity. So a lot of these issues can really be improved upon by, again, working on the systemic inflammation part, and then also working very safely and gently on some intervention strategies to work on the neural system, or stabilization, or whatever that the patient might need. Treatment has to be multifactorial. It really does. As we started off talking about upper cervical instability, that can really be impacted by tethered cord that's down lower. But then we also know that mast cell abnormal activity is a component of both of those conditions. So typically, the majority of these patients have layered things going on, and those layers need to be worked through. It has to be part of the treatment plan. So thank you for listening. I hope it was at least a little bit interesting and learning on some of the neurological stuff that is actually much more prevalent in this population. Many different references for anybody who wanted to go through and look at any of these references that are out there. And that concludes our neurological presentation for today. Thank you for listening.